Good evening, dear professors and colleagues. I'm Heba Naggar, lecturer of radiodiagnosis at Ain Shams University Hospitals. And today I'm talking about peritoneal metastasis, PET-CT, the keen observer, with some cases review from our nuclear medicine and PET-CT unit. As we all know, peritoneum is a large serosal membrane that's divided into two layers. The parietal peritoneum, which covers the anterior abdominal cavity, and the visceral peritoneum, which covers the organs partially or completely. In males, it forms a closed sac, while in females, it's perforated by the lateral ends of the fallopian tubes. Well, peritoneum is a favorable site for neoplastic lesions from primary and secondary malignancies, with the latter representing the majority. And detecting these deposits is crucial in the diagnosis and staging of the primary tumor to set the adequate treatment plan. Routes of spread, as we all know, is through direct invasion from nearby organ, intraperitoneal seeding, lymphatic, and hematogenous spread. PET scan represents a new tool for the assessment of the peritoneal deposits. PET scan also, though lacks the morphological details, yet it has the ability to reveal the deposits through their FDG avidity, which makes the lesions appear obvious between the surroundings. As in this Q-clear image, as you can all see, there here is the lesion, which appears black on the white background, which makes it very obvious. Peritoneal deposits appearance varies from minimal nodular thickening, as in this case, as you can see here, illustrated by the arrows. You can see here a small FDG-avid peritoneal deposit on the hepatic surface, or maybe large omental cakes. As you can see in this case, the abdominal cavity is occupied by large peritoneal omental cakes. Peritoneal deposits also might be very small and not clearly visualized or hidden between the viscera and missed in the conventional CT scan. As you can see in this image, here in the conventional single-phase contrast-enhanced CT, there are some peritoneal deposits that are hidden between the viscera. Where are they? We don't know. Now we check the combined or the fused images, and here they are. One of them is hiding behind the bowel loops, and the other one is just posterior to the anterior abdominal wall on the left side. Combining both PET and CT scans together allows the proper assessment of the anatomical details, actual site and size of the deposit, its metabolic activity, whether high or low, as well as its metabolic behavior and response in the follow-up. You can see here in this case there is a peritoneal deposit here in the left loin. Okay, but when we reviewed the Q-clear image, we found another black FDG-avid deposit on the right side. When we look again to the fused images, we see that there is another peritoneal deposit, maybe larger than the original one, on the right side. Also, in PET-CT scan, we can use the dual-point scan, the early and the delayed phases, which can discriminate between the deposit and the normal bowel activity in deposits with challenging site. Those were hiding in close proximity, for instance, to the bowel loop. We can take a look at this case here. We can see here a peritoneal plaque between the bowel loop. Now the question is it bowel activity or is it peritoneal deposit? We asked for delayed scan, and here it is. The activity is persistent at the same site, and it also shows increase in the SUV max, keeping with its neoplastic nature. FDG-avid primary tumors will have FDG-avid deposits, which is called the metabolic signature. So detecting the peritoneal deposit is not always that simple, because as we mentioned before, PET-CT has all the above mentioned advantages, yet it depends on the FDG avidity of the lesion, and those which are not FDG avid or insignificantly avid will remain a challenge when too small or in tricky sites. Now we'll review some of the cases, and we'll start with case number 1, and this was a middle-aged male diagnosed with small bowel lymphoma, received chemotherapy, and was referred for reassessment with PET-CT. We'll review first the single-phase contrast-enhanced CT images, and as you can see, there are large omental cakes occupying the abdominal cavity associated with ascites. This is a very simple case and very obvious from the CT. When we look at the fused images, you can see that all the peritoneal or the omental cakes are FDG avid with high SUV max and associated with non-FDG avid ascites. This was a simple one. Now, case number 2, this was a 40-year-old male patient, known case of cancer colon, underwent surgical resection and was referred for metastatic workup before therapy. Now, these are the CT images. What we can see grossly or generally, we can see something obvious at the operative bed, but we can see a hypodense focal lesion in the liver. Now let's move to the fused images, and here we can see the hepatic focal lesion is FDG avid, which was proved to be a metastatic deposit from the cancer. And at the operative bed, we can see a small nodular thickening at the presacral fascia with low-grade metabolic activity. We asked for a delayed scan, which was obtained 1 hour after the original scan, and here is the result. We can see that there is persistent metabolic activity at the small nodular thickening at the presacral fascia and shows increase in the SUV max in the delayed images, confirming, and this case was reported recurrence at the operative bed. Case number 3, 25-year-old male patient, known case also of cancer colon, underwent surgical resection and also was referred for metastatic workup before therapy. And here in the images, we can see there is a peritoneal plaque at the left hypochondrium related to the bowel loops, persistent also in the delayed CT. When we look at the combined or fused images, we can see there is an FDG avid peritoneal plaque here that is persistent and shows increase in the SUV max in the delayed scan. This patient received treatment and was referred for short-term follow-up after 3 months, and you can see there is dramatic and marked anatomical and metabolic regression in the size and the metabolic activity of this peritoneal plaque, and this case was reported to have a favorable therapeutic response. In case number 4, we have a 50-year-old female patient, known case of ovarian tumor, who underwent total abdominal hysterectomy and bilateral salpingio-oophorectomy. She received chemotherapy and was referred for follow-up. Let's check the CT images grossly. What we can see, can you see anything? Can anyone see anything? Okay. What I can see, obvious here, is there is something rounded, soft tissue here next to the gastric wall. Then proceed to the fused images. This one was proved to be a peritoneal deposit, but there are multiple and variable size small peritoneal deposits that were scattered. Here is another one related to the transverse colon. Another one here hiding between the bowel loops. And another one there just posterior to the abdominal wall on the right side, as you can see. In case number 5, this was a child, 15-year-old, known case of lymphoma and was referred for follow-up. There are the contrast-enhanced single-phase CT images, and you can see that there are multiple hepatic focal lesions. As we scan through the rest of the CT, it appears grossly no gross lesions, but when we review the combined or the fused images, we can see the hepatic focal lesions. Of course, they are FDG avid, but here there is a small peritoneal deposit, as you can see in the second image, arrowed, that shows metabolic activity and surrounding peritoneal haziness. As we proceed, we can see another peritoneal deposits hiding between the bowel loops, and another one seen resting on the prerectal fascia. In case number 6, middle-aged female discovered during routine ultrasound, bilateral ovarian simple and complicated cyst by ultrasound. She was referred to a gynecologist who suggested laparoscopic assessment and biopsy of the ovarian lesions. And she was diagnosed with left ovarian clear cell carcinoma and referred for metastatic workup. As we review the CT images, we can see in the first one, the right adnexal simple cyst is very obvious, and the left cyst, it's not a complicated, it's a complex cyst because it has a soft tissue component. But as we go through the rest of the scan, we can see any gross lesions apart from these 2 lesions and minimal fluid collection. When we review the combined images, we can see here that the right adnexal cyst is not FDG avid, it's a simple cyst. The left one is highly metabolic, shows high metabolic activity, and what is the combined imaging is added is that there are multiple small-sized peritoneal deposits arranged in a linear pattern surrounding the uterus and the left adnexal lesion. And this is the last case. This is a 43-year-old male patient, known case of neuroendocrine tumor, who underwent surgical resection and was referred for metastatic workup and follow-up after the operation. What we can see here in the CT images, I can see well-defined soft tissue peritoneal deposit arrowed. And the rest of the CT, I can see something gross, and here in these images we can see 2 enlarged retropancreatic lymph nodes. The rest of the pancreas appears okay. When we look at the fused images, we see the peritoneal deposit is obvious here and it shows no FDG avidity. As we go through the scan, there is another one posterior to the transverse colon, and again it's not FDG avid. As we continue, there are 2 tiny deposits lateral to the gastric wall, and the 2 retropancreatic lymph nodes, they are non-FDG avid. And this case is a neuroendocrine tumor. A neuroendocrine tumor are known to be non-FDG avid. So these deposits could have been missed if we don't look clearly at the CT images. And this case was reported, and my colleague suggested the patient would do the follow-ups later with gallium dotatate. My take-home message is peritoneum represents a common site for primary and secondary deposits, with the latter being more common. Peritoneal deposits have various shapes in imaging, and their diagnosis with conventional CT might represent a challenge if too small or in hidden places. PET-CT is an excellent tool for picking up the tricky lesions, assess their site size and their metabolic behavior. Non-FDG avid primary tumor and their metastatic lesions may be missed if we only dependent on the PET images and neglected to search in the CT images carefully. Thank you.